And before to start, we want to let you understand our philosophy. We think that nowadays we are in a modern society. We need to have a modern treatment plan approach, and in every cases we need to link all the different branches of dentistry all together. But this is not our only purpose. We need also to think that in between, in the middle of this treatment plan, it has to be always the same person, that is the patient. So it's really nice from Maurice that having invited us here, closing this meeting that has been started from a dental team approach, and we are going to try to share in the next 30 minutes our dental team approach. That is not like only technicians, it's not only components of the dental team, but it's also the patient that needs to be involved inside of the treatment plan every day more. And we need to listen to him and try to fulfill all their requests when it's possible. So, in order to begin this talk, I want you to present this case that basically sum up what we saw this morning with Dr. Khan, with Dr. Tano. From this case, you see immediately that it's important to start to evaluate all the different parameters, aesthetic parameters, function parameters, starting to collect all the different information in order to formulate a correct diagnosis. So starting from a photographic set with different angulation, trying to start to evaluating all the different facial aspect, buccal lingual aspect, taking PAs, trying to understand in which kind of biotype we are in. This will guide us to formulate a correct diagnosis that will lead us to, and will lead all the dental team components to formulate a correct treatment plan for this kind of patient. And we confirm this patient of being a type 1 socket with thin biotype, and we decided to go for an immediate implant loading procedure.
When an implant is placed in an anterior type 1 socket, there is always a gap, a jumping distance to manage. Literature tells us that bone remodeling always occurs in the first healing phases, altering the buccal lingual dimension. The question now is, with a correct surgical and prosthetical protocol, is it possible to control and to overcome this problem? This is the surgical protocol we have been using with this type of case during the last 3 years. It provides, after a minimally invasive extraction and a flapless implant procedures, an overbeading of the socket site by placing a connective tissue graft taken from the palate and a dual zone bone grafting with puros into the socket to avoid any collapse of the buccal lingual contour at the end of the treatment process. Managing properly the critical and subcritical emergence profile of the provisional restoration is a crucial part of the treatment process. And also smoothing and steam cleaning. It will help the provisional itself to fulfill its role, supporting the soft tissue mechanically and physically, and seal the socket, protecting the graft inside, avoiding possible infections.
So, as you can see, what Alessandro showed to you, right now we are at the 3-month follow-up, and this is exactly the picture that you want to see when we first unscrew in this kind of patient the provisional restoration. We want to see a thick, robust tissue that will help to mimic our final rehabilitation and all the prosthetic components underneath, and we want to have also a good vertical components, because we need to give to our technician the possibility to develop the correct emergence profile of our final crown. And so from here we're gonna step back a little bit, we're gonna do a step backwards, and we're gonna try to see where where and how the new technologies are helping us right now in restoring this kind of case. Because we think that really the goal of today and the goal of this entire meeting was to understand when, where, how, and why the new technologies, the new digital possibilities were entering in the multidisciplinary treatment plan process. And in order to do this, we are going to do a little step backward, and we are going to try to give you our point of view on this.
So let's start our overview with simple definitions. What does exactly CAD/CAM mean? Thanks to the computer-aided design, technician could design its own prosthetic framework. While the computer-aided manufacturing permits, thanks to an industrial process, to produce the designed object with a homogeneous raw material. These two definitions are already clear to all of you, but recently it has been introduced a new concept, computer-aided impressioning, which permits to record three-dimensionally the oral cavity situation thanks to advent of intraoral scanner machines. As an example, let's consider this case restored 2009, where new technologies and new materials were getting inside more and more the treatment plan. Complex case rehabilitation with a high functional issue due to its pronounced third class, periodontal and aesthetic problematics, very challenging case. Especially a full implant arch zirconia rehabilitation, specifically a full implant arch zirconia rehabilitation on the upper and a full arch zirconia restoration on natural dentition in the lower jaw were planned. But how new technologies helped the dental team in this case? Thanks to last generation scanner, combined with the specific components such as scanner buttons necessary to transfer the implant position, starting from the conventional prosthetic project, which is the fulcrum of the treatment plan, the technician was able to design the frameworks at the computer. Helped by the new software, the new software potential, he had all the major variables under control. He could check the volumes of the final restoration, having in front the implant screw hole axis, as you can see in the slide, and the framework design, all in the same picture. No more wax calibrated spatulas or silicone matrix were needed, but only by clicking the mouse, the technician precisely reduced the volumes. Thanks to this precision, we was able to better control the backings of the veneering ceramic, accurately design the framework to distribute the stress without losing strength in the final restoration. Notice the excellent work done by the technician Luca Dondi and Matteo Dondi, carefully checking the occlusion first on the model and then in the mouth, in where it has been possible to prosthetically compensate the third class, reestablishing the anterior guidance. Summarizing this first part, it is clear how important the advent of the new digital software have been in the technician workflow, allowing them to customize the framework design respecting volumes and thicknesses more accurately than the conventional protocol. This variable reduction permitted a standardization of the procedures, leading to a predictably not obtainable before without very talented and skilled dental technician. Like in this case, restored in 2003. And this revolution brought also to a faster workflow production, decreasing the difficulties on achieving passive fits.
So, what is important to understand is what is the goal of this modern dentistry? What is the goal of this digital revolution that is happening in the last years? The goal is to try to close this circle, trying to become completely digital. And in order to do this, in the last few years, have been developed several technological tools, such as the intraoral scanner, that have a specific workflow divided in 3 main points. The first part, and it's something that is going to, and has already changed the clinical workflow. We saw with Alessandro's that the technical workflow has already been changed by this revolution. But what about the clinical what about the clinical standpoint? What are the advantages that us as clinicians we have and we can achieve with these new instruments? And without forgetting that these instruments may help also our patient comfort, increasing their quality of the life also during the treatment plan, not only at the end of the treatment plan process. So we have these 3 steps that, of course, the first one is to capture and record the intraoral condition to the computer. These data were then sent, thanks to an iCloud platform, on an email to the dental technician that with the CAD and the CAD part, with the CAD and the CAM part will then produce the final manufacture. And let's see an example, a clinical example of how we can use and how we can try to close this fully digital circle. So let's take in consideration this 32-year-old patient, friends of mine that came to our office because he didn't like the shape and the shade of his crown. And of course, once again, standardized protocol. First thing to do, collect all the information that are possible. So starting taking pictures on different angles, starting to evaluating the X-rays, speaking with the patient. And of course, you can clearly see that we have several aesthetic issues from gingival asymmetries. We have gray. We have a gray color in the critical aesthetic interface between the teeth and the gingiva. We have a canting of the dental midline. We have these 2 restorations that are too bulky. So once we collected all the information, we started our treatment plan, and we wanted to be precise in every single step. And once we removed the crown, it was clear why these 2 restorations were too bulky. The technician didn't add the space, didn't have enough space in order to build a proper final restoration. So in order to be as much as conservative as possible, we decided to switch the finishing line, passing from a horizontal finishing line to a vertical finishing line that allowed us also to manage prosthetically only with the provisional restoration by adding some flowable composite while realigning the provisional restoration in the patient's mouth and managing also these gingival asymmetries. We thought about the patient. Any patient doesn't like to see us taking the blade out of our bench. So it's important. If we have the possibility, we don't use the blade, and we solve prosthetically a gingival asymmetries when it's possible. And one thing that we want to make clear is that it's not that all the new digital possibilities are changing our life in the sense that we don't mind if we have some blood, we don't mind if we have some saliva around when we are taking the impression. While we are taking the final impression, either digital or traditional, we need to know that blood and saliva are going to decrease the accuracy of our recording. And that can be a digital recording or a traditional recording. This doesn't change. We need to have pictures and patient looking like this at the day of our final impression. because we want to be the most accurate and the most precise and the most predictable as possible for our patient. So this is the day of the final digital impression. You can see that our system works with a little powder, with a little bit of powder, but it can also work without powder. In this case, we place the powder because it helps us to speed up a little bit the process. But if you don't want to use the powder, feel free not to do it, because it will only speed up the process. It will not create inaccuracies in your recording.
Those are some of our intraoral scanner highlights, which present several important benefits, such as real-time stitching, which permits to combine, together with the smart pixel sensor, the different photo shoots recorded and generate a real-time three-dimensional video on our screen. In my personal opinion, one of the great advantages of this new technology tool is that it enables the clinician to define the line of the preparation of the abutment immediately, prior to sending the files to the technician. This process is simplified and made more accurate thanks to the software's on-screen wizard on the right in the screen, on the left on your screen, and the two-dimensional depth position guide on the left. Then the software permits an easy understanding also for the non-expert operator. Moreover, it's possible to immediately check, for example, the shape and the convergence of the preparation. This is crucial for milling strategies purpose and to avoid the internal voids once the final restoration is cemented.
And see that also zirconia can be translucent. Of course, you need to work with high-quality zirconia. Of course, you need to work with the right dental technician that knows how to use the characteristic of the material that we are using to our own advantage. And and if everything has been done properly, this is the final result that you can achieve. And like this, we are sure that we improve the quality of the life of the patient. Now, I just want to show you a case similar to the previous one, but because I want to point out another advantage of the intraoral scanner. In this case, we basically did the same thing as the previous one. There was this redoing of these prosthetic crowns, trying to manage some gingival asymmetries. And one of the advantages of the intraoral scanning is that you can take the digital impression of one abutment at a time. And this is a big advantage, especially when you are dealing with vertical finishing line, because you want the second core to stay in place as much as it's possible in order to have a good retraction of the soft tissue, get the good soft tissue disclosure, and then let the laser beam of the intraoral scanner getting inside the sulcus. And the other day, I was showing the presentation with Maurice, and we made a joke because, of course, you know that they are worldwide famous for the one abutment, one time concept. And we made this joke that now it's not one abutment, one time, but with the intraoral scanner, we can say that it's one abutment at a time concept. And afterwards, this is the final restoration in place. Then all the data are sent to our dental technician. This is Matteo Dondi that is working on the designing the frameworks, knowing what are the characteristics of the material and knowing where to go and strengthen the weak areas of our final restoration. And in this case are the incisal margins, because we want to avoid cohesive chippings to our final restoration.
Let's now consider implants in the static zone in type 1 fresh extraction sockets. The dental team goal is to mimic the final rehabilitation in the patient's mouth This means not only implant survival, but also aesthetic implant prosthetic success. To obtain this, it is important not only to not open any flap and working with performing and correct implants geometries, but also to properly manage the soft tissue.
And now we are back to the picture of the first case. You see, now you know a little bit more about intraoral scanner, about the digital possibilities, and at the day of the digital impression, what are the advantages that these new technological tools are giving to us? We know that it took a lot of time for us to achieve a soft tissue like this, a thick, robust soft tissue like this, and we wanted to keep this. We know that when we unscrew the provisional restoration, immediately the tissue tends to shrink. But there is one thing that doesn't shrink, and this is acrylic. So with the intraoral scanner, it's easy to take out the provisional restoration. We don't mind if the tissue is shrinking in the patient's mouth, because we know that here we are being precise. And takes like really 1 minute. And you can see here clinically and what is appearing on our computer screen. It's very easy. And of course, the workflow goes on. The dental Matteo Dondi designed the framework. We try in the framework always trying to evaluate the baccal-lingual dimension because we don't want any shrinkage. And of course, the facial dimension and controlling with the CBCT. And you can see that this protocol works. We manage at the 1-year follow-ups to have hard and soft tissue preservation. And this is great for our patient because they can have a final restoration that is successful. Not only successful from an implant point of view, but also from a prosthetic and an aesthetic point of view.
Go.
So we need to understand, because another important thing, our patient asks us to be predictable, and so we need to be and use predictable approach to our patient. So we show you one of the case of that protocol that we are developing together with Maurice and Harry and David. But let's see this similar case that is a lateral incisor that is failing. You see here always baccal-lingual dimension evaluation, biotype evaluation, and then once the implant is placed, once the provisional it has been shaped, we can go for the final restoration. And here we have a zirconia abutment with a titanium base produced thanks to the CAD/CAM technologies. And we are moving forward till the end of the restoration without forgetting every detail of our treatment plans. Cementation is very important, so we need to pay attention also in this kind of protocols. During the cementation phase, when it's possible, put a retraction cord that will help you to remove easily the residual cement, because residual cement can lead to perimplantitis over time. And what is most important is to have a proper balance between the white and the pink aesthetic. This is the restoration that we want to see at the end of our treatment plan. And we need to be predictable. So this is a third case. You see a canine, so we have a big gap to manage. In the canine, we always have big gap to manage. And overbuilding the socket, we were able to have an adequate stable bone volume and architecture by developing and maintaining the appropriate soft tissue contour. You can see here how big was this socket, and you can see here the day of the final cementation that we managed to maintain and to preserve everything. And this is the 2-year follow-up. From a clinical standpoint, look in a patient with a thin gingival biotype, and she has recession on the 2 adjacent teeth, but our soft tissue implant is stable. And you look also not only at the soft tissue, but also at the hard tissue with the CBCT control at 2 years follow-up. So this is very important. And this is what we want to see in our CBCT controls. And you can see this that Joseph Kahn this morning said is the most critical area when we are planning and when we are working on in dealing with the static area. We manage to have the correct volume of hard and soft tissue. So as I was telling you, what are the patients asking us? To being predictable. And nowadays, patients are not asking only to be predictable, but they are also happy when we are fast. Because today's patients, less time they sit on the dental chair, the more are satisfied. And our goal is to try to understand how to fulfill their requests, so to speed up the process, but without losing the final quality of our work. So this is why it's important to combine the new digital possibilities, the new materials, with our traditional background, with our biological background, in order to fulfill their request. And let's take in consideration this case that in 2013 of these failing molars. Of course, biological and literature are always helping us. So we need to know how to extract a molar, define which kind of socket site is this specific molar, and placing the correct implant with the proper dimension and with the proper position in all the three-dimensional space of the socket. And then once we waited for the healing of our implants, we place a provisional restoration, paying a lot of attention in all the aesthetics and functional parameters of our provisional restoration. Because thanks to the digital solution, we can not only replicate the soft tissue tunnel, but we can replicate also the function of the patient. And this is what we did in this case. Thanks to lithium disilicate, we were able to restore in 1 day once the implant was integrated. By placing the intraoral impression, taking the scan of the provisional, and then going for the final restoration in 1 day. So this is important. But what is important is also not to lose the final quality of our product.
So let's take now in consideration this periodontal case with forcation involvement with 2 walls infra-bony defects. Before working on the final prosthetic restoration, it is mandatory to first treat the periodontal disease, reestablishing a positive bone and tissue architecture. Notice in the right side picture the tissue healing the day of the final digital impression, with already the powder in place. Look in the top left picture, the perfectly shaped provisional restoration in place, functionalized by the patient. Thanks to the new technologies and new materials today, we are able to duplicate in a predictable way the function done by the patient of the provisional restoration. It is in fact recorded with the dental abutments, and once all the scans are matched, the final restoration is produced. It is exactly in cases such as this one where the digital solution allows great benefits in terms of time consuming during the clinical technical workflow. Now we can deliver the final restoration in a complex case like this with only one try-in, the Fremor try-in of the hybrid translucent monolithic zirconia. And here the final restoration in place with the checking of the occlusal dynamics. This perioprosthetic protocol has been described by Carnevale's group more than 15 years ago in literature, with a mean survival rate of 93% at 10-year follow-up. This alternative avoids, when indicated, more invasive regenerative implant procedures, reducing the cost and the morbidity to the patient. But the question that might arise is if this innovative approach could be predictable also for full mouth rehabilitation. To answer these questions is now described a 56-year-old female patient who presented at first visit referring to not being able to chew anymore because of the continuous dissementation of the upper right bridge and the absence of the upper left bridge performed 10 years before. The dental team immediately understood that treatment of an upper partially edentulous patient with a high aesthetic risk and poor posterior bone quality and quantity combined with a prosthesis on implant and natural dentition in the same arch entails considerable surgical and prosthetic difficulties to reach a final restoration that perfectly integrates into the final smile and the face of the patient. Also, the sequences of the treatment plan, corrective therapies must have been well coordinated to give the patient from the very early stages a comfortable aesthetics and functional fixed restoration.
So far we saw a single tooth rehabilitation, we saw a partial multidisciplinary rehabilitation, and let's see how can we deal with a full arch rehabilitation integrating digital solution in our protocols. So what we did in this case was exactly what we did in the two previous cases. We studied together with Luca and Matteo carefully the second provisional restoration as it was the final rehabilitation of the patient, paying attention of all the function and all the occlusal path of this patient, working also with pantographic registration to give to them the most possible information available in order to give them the possibility to build a provisional restoration that was basically perfect. And then we left the provisional in place for 3 months because we want the patient to characterize air function in our provisional restoration. Because now we know that with the intraoral scanner, we can copy and replicate this function. And using the new materials, we can go to the final restoration, knowing exactly what is the function for this specific patient. And of course, it's always important to involve her in the treatment plan. We show her the videos, we put the provisional in place, and we do all the function evaluation, and then we show the videos to her. And it happened that she didn't like this pin component. So we sit with her and we decided that was possible to deal with that pin component and to trying to solve also that problem with a simple enhancement of the soft tissue using and working also with the Pontic of the provisional restoration. And then we went with this multiple acquisition digital design technique that was first described by Federico Boni and Luca Dondi at the Italian Academy of Prosthetic Dentistry, in where we divided the scan of the full mouth in 3 parts. Because it's important to know also the limitation of today's possibilities. We know that the intraoral scanner are not as accurate as the traditional protocols in taking a full arch impression. So in order to overcome this problem, we divided the arch in 3 parts, and we took all this digital scan. Of course, you need to be very precise in every single step of your treatment plan. So you have to refine the preparation, you have to post-process the file, you have to lighten it, and you have to polish your preparation. And then, of course, it's all Matteo and Luca's work that thanks to the new digital possibility, they don't need to work on the function because these 2 grooves were done by the patient, so they don't need to change that because this is exactly custom by them. They need to work with their knowledge, with their traditional knowledge. Which are the most weak areas in this patient? The incisal margin. So let's do this specific design that they have invented, that they created, and it is called ZIL, zirconium side laminate design. And you can see that the new digital solution are giving you all the help of the world, because you have always on the left side of your screen a wizard that is telling you exactly what to do and what not to do. And then, of course, there is the tradition that meets innovation, because we are moving into a fully digital process, but there is one thing that nobody can change and no machine can change. It is the artistic skill, the art of our dental technician. So we need to give them, and we need to have them, and we need them because we want to have the best looking final prosthesis possible. And by doing this, we are managing and we are fulfilling the patient request.
So cementation is the final step of the treatment plan sequence, but it has not to be underestimated. It's crucial. Using appropriate retraction cords and superfluous in the bridges and braziers would help to remove all the cement excesses, avoiding soft tissue inflammation. It is crucial to remember that the cement residuals could be dangerous, especially around the implants, causing periimplantitis of the time. Here is the final restoration completed and cemented. Note how, thanks to the appropriate management of the corrective surgical therapies, the prosthetically guided implant placement, and the correct soft tissue management, it has been possible to rehabilitate a very challenging case of partial edentulism with an aesthetic and a functional success. This has permitted to fulfill the patient's main request, to avoid any kind of removable prosthesis during the entire treatment process. Look how final rehabilitation fits perfectly in the patient's smile. The 1 year radiographic follow-up confirms the crown's precision and the stability of the marginal bone around the osseointegrating implants.
So trying to sum up everything, we are living in a modern society and we need to have modern treatment plan approach. This means not only to have clinician goals that are the classic surgical, prosthetic, and ergonomic goals, but also to have like patient goals. We need to give them a quality of the life, and we need to improve the quality of their life, not only at the end of the therapy, but also during the whole treatment plan process. And this can be done by using effective provisional, by reducing the surgical steps when it's possible, and the overall treatment time. And of course, what we have been said during all this, what it has been taught us in all these 3 days, we need to know that the new technologies are, yes, a great tool that are simplifying and improving our daily clinical routine, but standardized protocols, the in-depth knowledge of the materials and of the characteristic of the materials, the carefully performed clinical procedure are still of utmost importance in order to obtain satisfactory result. And in this digital era, the most important part to understand is that the daily improvement of the new technologies requires the dental team to be constantly up to date. And by doing this, we need to know that something that is new today is going to be old tomorrow. And for example, let's take this last case, in the last 2 minutes, full arch implants, upper restoration, full arch implant, lower restoration of this patient. What we need to do? First of all, we need to improve his quality of the life with a correct provisional restoration in the mouth, avoiding any kind of removable denture or removable prosthesis. With this, we can record with the intraoral scanner or with the intraoral scanner the situation of the mouth, and we have the possibility to have before This is important. Before the surgical step, the immediate loaded provisional restoration in our desk, before before touching the patient. This is important. In this case, we did a control group, that is the upper jaw, that is going to be restored in a traditional way, and a test group, that is the lower arch, that is going to be restored in a completely digital approach, also in this kind of complex cases. And here you can see the traditional approach, so the traditional transfer of the implant position to our dental technician, thanks to this transfer plate. This is a published article together with Maurice and Henry and David on the revitalized solution. And this was what it has been done in the upper arch, something that we already tested, something that we know about it. And we compare it with the lower arch, in where after the surgery of this immediate post-extractive implant placement, thanks to this digital transfer plate, we digitally transfer the implant position to our dental technician, that put that in the CAD software. We already have the provisional restoration before the surgery, and what he had to do was only to tell to the machine where to do the holes. And thanks to the cemented titanium base, we had the possibility to screw the day after, screw in the provisional restoration. You can see here in the traditional way in the upper arch, completely digital way with PMMA multi-layered material in the lower arch. And of course, this is something new. And this is something that we did like at the beginning of this year. We just unscrewed the provisional restoration, and this story needs to be continued. Thank you very much.
Thank you.